Our objectives include defining a ventilator, differentiating between respiratory and mechanical respiration, explaining ventilator types, identifying indications, troubleshooting management, and discussing basic care for ventilated patients. A ventilator is a machine that assists with the exchange of oxygen and carbon dioxide, known as artificial respiration. Natural breathing involves negative inspiratory force, pulling air into the lungs. Mechanical ventilation uses positive inspiratory pressure, pushing air into the lungs.
Mechanical ventilation can be categorized into negative pressure, which is non-invasive, and positive pressure, which is invasive. Early negative pressure ventilators, like the iron lung, encase the patient's body to generate negative pressure. Their use is limited today due to restrictions on positioning and movement. Our focus, however, will be on positive pressure ventilators. Indications for initiating mechanical ventilation include acute respiratory failure, prophylactic ventilatory support, and hyperventilation therapy. Criteria for ventilatory support, based on pulmonary function studies, include respiratory rate greater than 35 breaths per minute, tidal volume less than 5 milliliters per kilogram body weight, and vital capacity less than 15 milliliter per kilogram body weight. Ventilation is also indicated based on arterial blood gases, such as a pH less than 7.25, PaO2 less than 60 millimeters of mercury, and PaCO2 greater than 50 millimeters of mercury. A contraindication is an untreated pneumothorax. Relative contraindications include the patient's informed consent, medical futility, and the reduction or termination of patient pain and suffering. Essential components for mechanical ventilation include the patient, an artificial airway, the ventilator circuit, the mechanical ventilator, a power source, and an oxygen supply. Artificial airways include tracheal intubation, supraglottic airways, and tracheostomy. The intubation procedure requires checking and assembling equipment, such as the oxygen flow meter, suction apparatus, ambu bag, laryngoscope, ET tubes, and sterile gloves. The next step in the procedure is to position the patient into the sniffing position to facilitate intubation. Pre-oxygenate the patient with 100% oxygen. Intubation attempts should not exceed 30 seconds. If unsuccessful, ventilate with 100% oxygen for 3 to 5 minutes before reattempting. Then, insert the laryngoscope. After displacing the epiglottis, insert the ETT to the appropriate depth. Confirm tube position by auscultation, bilateral chest rise, tube location at the teeth, and using a CO2 detector. Finally, stabilize the ETT. Types of mechanical ventilators include transport, intensive care, neonatal, and positive airway pressure ventilators for non-invasive ventilation. Positive pressure ventilators are classified by how the inspiratory phase ends: pressure cycled, volume cycled, or time cycled. A volume cycled ventilator terminates inspiration after a preset tidal volume is delivered. A pressure cycled ventilator terminates inspiration when a specific airway pressure is reached. A time cycled ventilator ends inspiration after a preset inspiratory time has elapsed. These are mainly used in pediatric intensive care areas, not adult critical care settings. Modes of ventilation describe how the machine ventilates the patient and how much the patient participates in their own breathing. Each mode determines the amount of work of breathing the patient has to do. Volume modes of ventilation include controlled mandatory ventilation, or CMV, assisted mandatory ventilation, or AMV, intermittent mandatory ventilation, or IMV, and synchronized intermittent mandatory ventilation, or SIMV. Pressure modes include pressure-controlled ventilation, pressure support ventilation, continuous positive airway pressure, positive end expiratory pressure, and non-invasive bilevel positive airway pressure ventilation. In control mode, the ventilator delivers preset volumes at a preset rate and flow. The patient cannot generate spontaneous breaths. In assist/control mode, the ventilator delivers set volumes and flow, but each patient-generated effort is also delivered at the set volume and flow rate. Assist control is a volume or pressure control mode. Parameters to set include volume or pressure, rate, inspiratory time, and fraction of inspired oxygen. In assist control, machine breaths deliver the set volume or pressure. For spontaneous breaths, the ventilator delivers the full set volume or pressure and inspiratory time. This mode provides the most support. Synchronized intermittent mandatory ventilation, or SIMV, delivers a preset number of breaths at a set volume and flow rate while allowing the patient to take spontaneous breaths in between. It is a moderate support and works well for weaning. Pressure-regulated volume control, or PRVC, is a volume-targeted pressure-limited mode. It delivers a set volume with the lowest required peak pressure and adjusts with each breath, often with a decelerating flow pattern. Advantages of PRVC include a decelerating inspiratory flow pattern and automatic pressure adjustment for changes in compliance and resistance. It guarantees tidal volume, limits volutrauma, and prevents hypoventilation. Positive end expiratory pressure, or PEEP, is an adjunct to vent modes. It is the pressure remaining in the lung at the end of the expiratory phase, used to keep collapsing lung units open and improve oxygenation, usually set at 5 to 10 cmH2O. This slide is currently blank. Continuous positive airway pressure, or CPAP, is a mode where a preset pressure is present throughout both the inspiratory and expiratory phases. CPAP prevents alveoli collapse, improving oxygenation and reducing the work of breathing. It is commonly used to evaluate readiness for extubation. Inverse ratio ventilation, or IRV, reverses the inspiratory to expiratory ratio so that inspiratory time is equal to or longer than expiratory time. It is used with pressure control to improve oxygenation by expanding stiff alveoli using longer distending times. With decreased expiratory time in IRV, monitoring for hyperinflation or auto-PEEP is essential. Increased mean airway pressure in PCV can decrease cardiac output, so hemodynamic status must be closely monitored. IRV is used to limit plateau pressures and treat severe acute respiratory distress syndrome. Initial ventilator settings involve selecting the mode, setting sensitivity, tidal volume, rate, inspiratory flow, PEEP, pressure limit, inspiratory time, and fraction of inspired oxygen. A ventilator-delivered breath can be initiated by pressure triggering, sensing negative airway pressure, or flow by triggering, sensing a reduction in continuous gas flow, indicating the patient's effort to initiate a breath. After setting the ventilator, obtain an arterial blood gas about 30 minutes later to check the patient's oxygenation and ventilation status. The goal is to keep the patient's acid-base balance within a normal physiological range. Initial tidal volume for ventilated adults is typically 6 to 12 milliliters per kilogram of ideal body weight, adjusted for conditions like ARDS. The respiratory rate is usually 8 to 12 breaths per minute and should be adjusted to minimize auto-PEEP. Minute ventilation is determined by multiplying the tidal volume by the respiratory rate, with a normal range of 5 to 10 liters per minute. Adjustments based on arterial blood gas results are necessary to maintain a normal PaCO2. Initial inspiratory flow is often set to deliver inspiration in about 1 second, achieving an inspiratory to expiratory ratio of approximately 1 to 2 or less. Initial peak flow is about 60 liters per minute, adjusted to meet the patient's inspiratory demand. This slide displays a diagram illustrating the expiratory flow pattern and the peak expiratory flow rate. PEEP is initially set at 3 to 5 centimeters H2O, with subsequent changes based on ABG results. FiO2 is initially 100%, then kept below 50% after stabilization to avoid oxygen-induced lung injuries like absorption atelectasis and oxygen toxicity. A sigh is a deep breath with a volume greater than the tidal volume, used to prevent atelectasis. Sigh volume is typically 1.5 to 2 times the tidal volume, administered 4 to 8 times per hour. Ventilator air must be warmed and humidified, with humidifier temperatures kept close to body temperature. Ventilator alarm settings include the high minute ventilation alarm, set 2 liters per minute or 10% to 15% above baseline. This alarm often indicates the patient is becoming tachypneic due to respiratory distress. The high respiratory rate alarm is set 10 to 15 BPM over the observed rate and signals patient tachypnea. The low exhaled tidal volume alarm, set 100 milliliters or 10% to 15% lower than expired mechanical tidal volume, can be caused by a system leak, circuit disconnection, or ETT cuff leak. The low inspiratory pressure alarm is set 10 to 15 centimeters H2O below the observed peak inspiratory pressure. Causes include a system leak, circuit disconnection, or an ETT cuff leak. High/low PEEP/CPAP alarms are baseline alarms. High PEEP alarms are set 3 to 5 centimeters H2O above the PEEP and can signal circuit or exhalation manifold obstruction or auto-PEEP. Low PEEP alarms are set 2 to 5 centimeters H2O below PEEP and may indicate a circuit disconnect. Common problems when troubleshooting the ventilator include high peak pressures, which can be seen in patients with COPD, ventilator asynchrony, or ARDS.